Yes.
Yeah. Do you hear me?
Yes. Continue, please.
Yeah. Okay. Assalamu alaikum wa rahmatullahi wa barakatuh. And thanks a lot for the organizing committee for selecting my case as one of the cases to be presented today. It's my pleasure to present this case, which is actually a very rare case from Saudi Arabia. And it will be about fever with Berber crash and an eschar, a health problem that may be of concern. In April 2019, a 59-year-old Saudi camel shepherd from Riyadh province came to our hospital's ER because of fever, headache, skin rash, and cough. His skin rash started a few days after fever and chills. He was diabetic, on insulin with no history of traveling abroad. He used to remove Gerdan or Korad, which is an Arabic word that in English corresponds to ticks. And this was from his camel's skin, as was seen in a video sent by the patient to us. On examination, his temperature was 38.5 Celsius, but otherwise he was generally well. He had a widespread Berber maculopapular rash sparing the face and mucous membranes. His dermoscopic diascopy showed non-blanchability of the rash. There was also a minimally irritating eschar on his back. Our preliminary diagnosis was fever with Berber crash and an eschar, secondary to a spotted fever rickettsiosis, or SFR. Our differential diagnosis was viral infection such as enterovirus infection and also small vessel vasculitis. He was admitted to our hospital and was thoroughly investigated. His basic laboratory workup showed neutrophil leukocytosis and lymphopenia, hyponatremia, and markedly elevated fasting blood glucose level and hemoglobin A1C. His negative and positive acute phase reactants showed remarkable change, indicating the presence of severe acute inflammation. His basic infectious disease and anti-nuclear antibody laboratory workup was unremarkable. However, rickettsial infection serology revealed high titers of Rickettsia IgG and IgM, and also of Rickettsia typhi IgG and IgM. This was explained by cross-reactivity between the Rickettsia antigens and Rickettsia typhi antigens, but not due to coexistent infection. His chest and abdominal pelvic imaging was unremarkable. eschar histopathology showed a wedge-shaped inflammatory process that extends deeply into the dermis, together with coagulative necrosis and other findings consistent with an arthropod bite reaction. And the tick Rickettsiosis sanguinus was the incriminated vector. Our final diagnosis was a spotted fever rickettsiosis, mostly caused by Rickettsia. However, neither molecular testing such as PCR nor isolation in culture was performed. As to the treatment, he responded very well to oral doxycycline, 100 milligrams by ID for 10 days, but not to the other antimicrobials, and this is evident here in the figure. Of note, all medications were prescribed before rickettsial serology and histopathology results show. On reviewing the literature, we found that until recent times, tick-borne viral disease such as Crimean Congo and al-khorma, hemorrhagic fevers, but not bacterial ones, such as rickettsiosis, were reported in Saudi Arabia. On May 6, 2019, our case was reported to the local office of the Infectious Diseases and Preventive Medicine Department, Ministry of Health, Khamis Mushayed. In August 2019, Elzin et al. Diagnosed another case of spotted fever rickettsiosis in a Saudi teenager from Riyadh province. Again from Riyadh province. He was diagnosed as acute meningitis secondary to rickettsy after a camel's tick bite. Together, these two cases have to direct the attention to the presence of this infection in Saudi Arabia, especially in Riyadh province. Our take-home messages included: spotted fever rickettsiosis should be considered in the differential diagnosis of fever and berberic rash with and without an eschar in Saudi Arabia. Further surveillance has to be performed to trace this infection, especially in camel shepherds, and that doxycycline must start once the disease is suspected to avoid complications, including death. And thanks a lot.
Thanks, Dr. Ahmed, for this comprehensive presentation.